Welcome to Fertilish, the podcast where we get real about fertility, infertility, and everything in between. I'm Laura.
And I'm Brandis. And whether you're knee-deep in treatments, just starting to ask questions, or somewhere in the ish of it all, you're in the right place.
Here we ditch the stigma, break down the science, and have candid conversations about the messy, emotional, and sometimes hilarious journey to growing a family and preserving your fertility.
So grab your coffee, your meds, or just your curiosity, and let's get into it. All right, so we are back for another episode of Fertilish, and I get questions about this topic a lot on my Instagram, but it's about a thin endometrial lining. What causes it, why it happens, what it means, and how we can fix it.
Yeah, absolutely. I think that this is something that in the fertility world, unfortunately, many people struggle with, and maybe don't know that there is a struggle there in the first place until it's time for a transfer. And so, obviously there's different types of transfers and some types of transfers, you're on medications to be able to, increase the thickness, but, for various reasons, their lining may not be getting thick enough, to where we would like it to be.
Yeah.
And so I think that's a common question, just among fertility patients in general, is like, what can I do to make sure I have this thick, fluffy lining?
Yeah. And this is in regards to, IUI, ovulation induction, timed intercourse at home, with ovulation induction. And so this goes for all kind of fertility treatments. The frustrating thing is that people out in the wild that get pregnant on their own, we're not looking at those endometrial linings.
Right.
So are people walking around with thin linings and have gotten pregnant and we just don't know? So that's kind of the hard part when we talk about this, is because, people that get pregnant without issue, we don't know what their linings are. And then the other part of it is, even with, because most of this is going to refer to embryo transfer cycles with IVF, we normally, if somebody has too thin of a cycle or too thin of a lining, we're canceling the cycle. And so a lot of studies don't show us really what thin linings are either. So, and I'll kind of go over the data we have about it, but, can people get pregnant with thin linings? Sure, we just don't know because we're not measuring that.
Right.
Unassisted pregnancies. But just for kind of a quick anatomy refresher, the uterus has 3 layers. So that outer part, or the outermost layer, being called the serosa. The inner part is called the myometrium, and that's that big muscle that causes cramps, that pushes a baby out, that does all the things muscle-wise. That's that middle layer. And then the inner layer is called the endometrium, which has its own layers. But this is the layer that sheds every month when we get a period, and that's actually the layer that we're measuring when we're looking at the endometrial lining. So we're not measuring the whole uterus, we're just looking at that lining. So when we're talking about, a lining thickness, we are looking at that in both fresh cycles and frozen transfer cycles. And so usually I like to have the same person measure the lining each time, because when we're measuring these on ultrasound, depending on how you're holding the ultrasound, where you're measuring from, we're talking millimeters of difference, which do make all the difference. And so I like people to kind of have the same person each time, or at least have been trained the same, which here we are, measuring that lining, because if you're a millimeter off, that can make a huge difference. But for a frozen embryo transfer cycle, there's multiple protocols, but it involves either your own estrogen or us giving you estrogen, exogenous estrogen, in kind of different forms. And we want that lining for a frozen transfer to be at least 7 millimeters and a structure we call trilaminar before we are starting you on progesterone. For fresh cycles, I like it to be a little higher at 8 millimeters and trilaminar before you're being exposed to progesterone, because we know that those do give us the highest chances of success. And you've done transfers. Have you ever like struggled getting a thicker lining or?
Fortunately, I haven't. I've been fortunate enough to, when it needed to be thick. Now I have I have had a slow start before, and needed to take some extra estrogen, when I was doing medicated cycles. And, yeah, so I have had to take an extra, tablet of estrogen or something, for a few days, and then it got us to where we needed to be. But fortunately, that's not something that I've experienced personally, at transfer, but I have had several patients that have reached out to me, or friends that have gone through treatment, that maybe have had a canceled cycle because their lining was too thin. And then, this one poor patient I was talking to last month, as a matter of fact, she had a previous canceled cycle, and then she got to like 7.2 or something like that. But because of previous canceled cycles, it was in her notes that we wanted it to be at 8, just to ensure. And then she went back and it was down to 6.8. So it was like under the 7. And so she was so devastated.
Yeah.
So she started looking into some therapies to kind of help thicken that lining up for future transfers.
Yeah. And so, I always stress to patients, to me, organization is more important than thickness. So I want to make sure that we are getting a pattern in the uterine lining called trilaminar. And it's called trilaminar because there are 3 layers. And actually, when you're looking at it on ultrasound, you can see the 3 layers. There's like a white line in the middle. And then we know, okay, it's a trilaminar lining. That is super important to me. Now, sometimes, when we're looking at the lining, it can be homogeneous. So we're not seeing those 3 layers. You can see kind of irregularities or defects in there, or it's not, not as structured as we want it to be. And so sometimes the reason that we're not getting that trilaminar appearance, it can be early progesterone exposure. So either the patient ovulated through meds or they ovulated on their own. So that's kind of one thing I'm looking at. So, let's look at the ovaries and see, did they grow a follicle? Did they ovulate? Let's look at blood work. Is progesterone, did that go up? Because we know progesterone compacts that lining down to get ready for implantation. So again, did they take PIO on accident and just not realize that they weren't supposed to take that medication? So ask the patient, what meds are you taking? So that's one thing, that can cause that. Polyps or fibroids in the uterus. Normally, we recommend you have a uterine evaluation, but if it's not looking like a trilaminar lining and somebody waived having those tests done, I start to think, okay, is there something in the uterus that we're missing?
Yeah.
Scar tissue in the uterus or uterine septum, that can cause the lining to kind of not look trilaminar, or, like we talked about, timing issues with ovulation or medication. And so that's the first thing I look for, is I want that lining nice and thick, but I want it trilaminar. So, I think about when you mentioned the person you talked to about the lining compacted down, was she exposed to progesterone? Did she ovulate through when that lining compacted? And then the other thing, I look at a lot is if somebody had an egg retrieval cycle, I reference that a lot. So I look at, what was your uterine lining at your peak during the egg retrieval cycle? So let's say their lining at their peak during an egg retrieval cycle was 6. That's likely the highest that they'll ever get. Because if your lining was at 6 when your estrogen was 3,000, why is it going to be 7 when your estrogen's at 20? So, I use that as a reference point. Likely that person's not going to get to an 8 or a 12. So, if it's 6 in trilaminar, that egg retrieval cycle kind of gives me a reference point to say, okay, and then vice versa. If their lining was at 10 at their peak and now it's only getting to 5, okay, well, maybe you can do better. Let's cancel that cycle.
Yeah, there's more potential there.
Yeah. So everyone, that lining of 7 is not attainable for everybody.
Yeah.
That trilaminar lining is. I would like it to be trilaminar. But it's important that your provider or whoever you're going to is using your egg retrieval cycle, if you have one, as kind of a reference point of what's attainable for you and your lining.
Mm-hmm.
So let's see, we talked about, kind of what thickness we want to see. As far as I mentioned, fresh cycle thickness is a little bit higher. So with some kind of, again, retrospective studies, they saw that pregnancy rates did drop with each millimeter below 8 millimeters in fresh cycles. And then in frozen cycles, those rates dropped below 7 millimeters. And again, these are kind of arbitrary guidelines we have because we're not looking at people's linings that are getting pregnant unassisted, and then usually people that don't get thick enough linings, we're canceling their cycles.
Mm-hmm.
So it's hard to say, if you have a lining of 5, would that be okay? We don't have data on it.
Yeah, I mean, because if you've gone through the process of IVF and then getting embryos and you've made it to transfer day, obviously, we're less willing to risk losing an embryo on a thin lining than what would have happened if you were, like you said, getting, pregnant on your own. And so, because the body is not going, oh, well, we're measuring the, you know.
Yeah.
It's just either happening or it's not happening.
Yeah.
And there's no one there to, like, record keep of it. So, there's not a little MA in the uterus keeping score of
telling you what your lining thickness
exactly.
is. Yeah. And so as far as, thickness goes, in those fresh cycles, in those studies that I referenced, those live birth rates for fresh cycles were plateauing after they reached that 10 to 12 millimeter mark. So nothing above that did they see, an increase in live birth rate.
Is there such thing as too thick?
I typically don't tell patients there's something as, there's too thick. I typically say no.
Okay.
I hardly ever cancel people for too thick of a lining.
I didn't know if there was like, okay, it got to a plateau at 10 to 12.
And then it went down after.
Yeah, right. Yep.
There haven't been like great studies that I've seen that have showed that. So we've had plenty of patients, especially here, that had, thick linings and have achieved a healthy live birth. So I'm more concerned if it's, super thin, we're not even getting to 5 or 6, or it's not trilaminar. Those are kind of my bigger issues that I'm looking for. And then with frozen cycles, the plateau of live birth was after 7 to 10 millimeters. So really, once we get it to 7, if it looks trilaminar, then we're good to start progesterone or to have you ovulate.
Okay.
They did see, though, less than 6 millimeters, and this was kind of just, a retrospective finding, that there was a significant drop in live birth rates less than 6 millimeters. But again, is that achievable for everybody, especially if it wasn't like that in a egg retrieval cycle? It just may not be. So aim for trilaminar, and then again, important to reference, what was my lining at that egg retrieval cycle? What was the peak? As far as causes of what causes a thin lining, there are, a lot of things we think about. So long-term exposure to birth control, certain types of birth control can cause this. So if you're taking combined or birth control pills, so estrogen and progesterone pills, if you're skipping those pills, the placebo pills to where you'll bleed, if you skip them, then you go without a period, which is fine. You can do that. But your lining tends to thin out. Same with progesterone-only pills, with the Depo-Provera injection. Let's see, the
Why-
Nexplanon.
Why is it thinning? Because it's not shedding, so it just naturally is just like it assimilates to like not shedding the lining.
Yeah, and you have that prolonged progesterone exposure. So with the Mirena IUD, some people spot on it or have light periods, but some people will stop getting a period. That's actually how the Mirena works. Is technically, in some people, the Mirena can like suppress ovulation. It doesn't do that in everybody. It actually works by thinning out that lining. And so, let's see, what else does that? Like I said, the Depo-Provera, the Nexplanon. I think those are all of them. So combined progesterone pills, IUDs, not the copper IUD, because that doesn't prevent ovulation and you still bleed on it. So a hormonal IUD or the Nexplanon or Depo-Provera, all of those things work by thinning the lining. So if somebody tells me, hey, I've been on this birth control and I didn't get a period for so long, typically I advise people to come off at minimum 3 to 6 months before they're wanting to conceive, to give the body a chance to kind of have unopposed estrogen for a while and to kind of regrow that lining to get a bleed. Occasionally, people won't get a bleed and will need to kind of supplement some estrogen priming to get that lining to grow nice and thick. And then they'll, bleed it off again unless they have PCOS or another type of issue going on. But sometimes it takes a while to get that lining thickness back. And then Depo-Provera is a longer one. I usually tell people you need to come off 18 months before you're going to start to try to conceive. If you're not ready to get pregnant, use a barrier method like condoms. But yeah, these things, they don't hurt your fertility, but they can take a while for that lining to kind of regulate again, especially if you're not getting a period.
That makes sense.
Which is crazy because I feel like people come off Depo and they try and get pregnant the next month and they're shocked when it doesn't happen or after 3 months. And it's like, well, I thought after 3 months, but sometimes that can stay in your system for up to 18 months.
Yeah, and it varies so greatly from person to person. Like, I took Depo myself at different intervals, and like I stopped and then went back on it, and it even for the same person, it varied so greatly for how long it took for my cycles to regulate again.
Yeah.
So it's wild how it just like affects each person so differently.
And it even shows us, how our counseling of patients could be better. Like, I've never worked in family practice besides in school. But, sometimes if we're giving patients, let's say somebody comes in and wants Depo-Provera, a big question should be, okay, well, when are you, and this is never a question, planning to have kids, or when do you want to have kids? And if it's, I just, maybe in a year, then I'm going to probably advise you against Depo-Provera and say, hey, let's look at other options, because you'd have to stop this within 6 months to get pregnant in 18 months.
Potentially. Yeah.
Yeah.
Right. Yeah.
Yeah, potentially. And there are so many patients that have that story that they were like, I thought it would just be easy because it's a shot every 3 months and I could stop it, but I would have never gotten on this birth control had I known. And so, counseling, I feel like could be better for sure.
No, I agree. Yeah, I mean, like the different options and then what the, effects of those are, and you're exactly right. Like there are going to be some options that are much better for short-term birth control options than other options. And, some, options are going to be better for patients who are looking at more long-term use. So yeah, not every option is necessarily applicable to each circumstance.
Yeah. Okay, so we talked about birth control or hormonal type history could be a cause of a thin lining, so that's something to think about. Normally when they come to us, they've been off birth control for a long time, but if for whatever reason they haven't, there's male factor, they have genetic abnormalities, then that's something to look at. Talk about bring up your past birth control use. Another reason is scar tissue or Asherman's syndrome in the uterus. So scar tissue can be caused from things like, IUD, if it was placed wrong, if there was a traumatic insertion, there was issues with it coming out. So that could be a cause of scar tissue. Previous DNC or pregnancy termination or C-section. These are all things that can cause scar tissue. A myomectomy or fibroid removals. A retained placenta. So, you gave birth, had hemorrhaging, and then had pieces of placenta or placenta that wouldn't come out. That's, can be a cause of scar tissue. Infection, pelvic inflammatory disease. All of these things can cause scar tissue, because I always tell people, no uterine surgery is completely harmless.
Right.
All of these things are always a risk. And sometimes, the scar tissue can be repaired with hysteroscopy. We can go in and try and repair it and do some things afterwards to try and help that heal so that, there doesn't become more scar tissue. But sometimes if the surgery that you had completely took out that layer that regenerates, or that basal cell layer of that endometrium, there's nothing left there to regenerate.
Yeah.
And not to say that, your surgery was botched, because some of these are life-saving surgeries and they need to do what they can to save your life. But, those are things that can happen and can also cause a thin lining.
Yeah, I mean, absolutely. Like, certain procedures are not without risk, obviously, but the benefits of them, outweigh the negative effects, but can still have additional, repercussions.
Yeah, and so when people, that's why we're even picky with which fibroids we remove, when we remove them, just because no surgery is without risk. And so anything to kind of minimize that is important. And that's part of the reason why. And then uterine abnormalities is another thing. So with people, we do a saline sonogram where we put saline in the uterus and then look with ultrasound. Normally the uterus, this is hard because it's not really on video most of the time, but lays flat, and then we expand it with saline, and we're able to look inside. Now, that's just a screening test. So if we see something abnormal, we'll say you need a hysteroscopy. So hysteroscopy is where we're putting a camera in the uterus. Usually you're asleep for it, and we're able to actually see with our eyes inside the uterus, and that's the gold standard for uterine cavity evaluation. So if I suspect, you shouldn't have scar tissue, you've been on birth control for a long time, or you've never been on it, I start to think, is there a uterine septum that we didn't catch, that, is there congenital defects of the uterus? Are there, we mentioned this, polyps or fibroids that the saline sonogram didn't catch? So then at that point I'm saying, okay, these things are crossed off. Let's actually put a camera in the uterus and make sure nothing's being missed.
And just FYI, is there a certain time of your cycle that is best to have a hysteroscopy?
Yeah, I usually we like to do it when the lining is thin. So cycle day 1 is their first day of full flow. And so usually we're doing these hysteroscopies or these tests anywhere between cycle day 5 to 12, when you've kind of shed that lining and it's thinned out. I know our doctors or providers here, and I'll even do diagnostic hysteroscopies, they'll do it at the time of egg retrieval, which lining's a little bit thicker at that point. But usually if we're looking, because you have a thin lining, I'd prefer that we do it in that first half of the cycle. So it's between cycle days 5 to 12, so we can make sure that lining is thin and we're really seeing what's going on.
Okay.
And as far as what we can do to improve lining, you talked about this, as far as estrogen. So you were taking estrogen by mouth. Did they increase frequency or route or?
Yeah, so from like 3 times a day to 4 times a day. So add an additional pill, and of course, never recommend this, but I was like, what's in the 5th one every now and then?
Now it's coming out. They're like, why is her estrogen 50,000?
I was like, oh, it's a little extra bump up in estrogen. No. Please just do what your providers tell you to do.
Do as I
Don't
say. Do
listen
as
to
we say on
me.
here, not as we do.
Yes. So when we have switched over to doing now we're our treatment plan is to do modified natural, but taking extra estrogen at the time, and that definitely helped tremendously and got me where I needed to be.
Okay, and when you remind me, you've done a modified natural.
One.
Did you have issues with lining thickness with that?
I didn't.
Okay, so see that's a point I'm going to get to. So with a medicated cycle, which is where we're giving you exogenous estrogen in either the form of pills by mouth, pills vaginally, shots, and patches. So those are all the routes we can give you of estrogen. Normally we start with estrogen by mouth. If I bring a patient back and their lining is not growing as I expect, typically I'll try a different route. So let's try adding estrogen vaginally and seeing if that works.
My favorite.
The best. Everyone, yeah, the worst. So if you come back, do we need to change the route? Should we add patches? Do we increase the frequency? Occasionally, we will add Viagra by mouth or vaginally, which does the same thing as it does in men, increases the blood flow to the uterus. So, that's something we occasionally will add. A Neupogen or PRP wash are some things we may add. Now, no matter kind of what we do, we're really not getting that lining thickness. Again, I'll reference back to your egg retrieval cycle and say, hey, what was this person's peak lining? If it's, a lot higher, maybe you just respond better to your own estrogen, which it sounds like kind of you do.
Yeah.
And so then I'll say, hey, let's switch to a modified natural or a natural and see if your lining doesn't get thick with your own estrogen. And sometimes that's all the change you need. You just respond better to your own estrogen than exogenous estrogen.
Yeah, and that's kind of why, that's part of the reason why we switched to modified natural is because the only times I've ever had, a confirmed pregnancy from a transfer is, modified natural. So it had been from a fresh transfer. And so we wanted to switch to that to kind of mimic as best as possible that. And I think that's part of the whole picture there is my body's just responding to my natural hormones better and has better receptivity to that than, taking medications.
Yeah, and that's what's so hard, I think, for me to just answer questions generally, especially I'll do Thursday questions on my Instagram when people will say, I had this transfer and it failed. What would you recommend?
There's so many different
There are so many things that go through our heads when we talk about transfers. As far as lining goes, was it thick enough? Was it trilaminar? Did it look how we wanted it to look? Have you had a hysteroscopy? What was the type of embryo? And sometimes I feel like, obviously, we don't explain all of our thinking to every patient when we're going through things. We'll ask you questions, but these are the things we're kind of reviewing in our head, and everything is so individualized and perfected to a T,
right,
that there is just so much that goes into it.
Well, and I am in some Facebook groups for people who are trying to conceive or have gone through IVF or, and I see that question a lot, what did 40-year-olds do to achieve a live birth? Well, just because that's what this one person did doesn't mean that that's going to work for you or that's going to be the best course of action. And being 40 is literally 1/1,000,000th of the equation.
Yeah.
There's so many other things. And you can have 10 40-year-olds and line them up, and they probably will all have a different protocol and treatment plan because there's so many variances in what they need and what's going to work best for them. And even if their labs look the same, they have the same antral follicle count, they have the same AMH, blah, 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 their bodies just might not respond the same.
Yeah.
And so there are things that you can't even see or predict because there's no way to predict the outcomes unless you've actually gone through the process to narrow it down and say like, oh, this does not work for this patient.
Yeah.
Let's try something else. Oh, this seems to work a little better. Maybe we can add this on. So as hard as it is, believe me, as a patient, as hard as it is, and it is so emotionally taxing and so physically taxing, and you literally just want to scream. Sometimes it truly is a matter of like taking what you know and what you can control and then trying it and seeing if it works. And then it's just a series of, let's see what works for you,
Yeah.
And so the further you get and the more times you try, the closer you get to the outcome that you want. And so, yeah, like sometimes there's just not things that we could predict.
Yeah. And well, and I get a lot of questions of, have you ever seen a patient get pregnant with a 3AA or a 3BB or a 5BB?
Yes and no.
And like I'll get that, and then I'll even see them because I'm a part of egg freezing groups because I froze my eggs, and people will get to the point where they thawed them, have made embryos, and now they're doing transfer, and it's like, yes, I have seen a patient get pregnant with a 5BB, but that 5BB was a euploid embryo. They didn't have Asherman's, which is scar tissue in the uterus. They have a different history than you do. Or this 5BB, though, this person had fibroids that were impinging on the cavity, or, this person had a blood clotting disorder. So yeah, you're right. There are so many aspects to it that it goes so beyond one data point.
Yeah.
So that's the tricky part of IVF is there are so many differences, or the girls will always tell me, oh, this patient said that they read online that you suggested who knows, Viagra for them, but then another patient stated that you said to try estrogen, so what's the better route? And it's like, no, because every case is so different,
right.
and we're not always going to suggest the same thing from person to person.
Yeah, and maybe this person has something that Viagra is contraindicated, that maybe they're on a different medication, or maybe they have an underlying health issue that like Viagra is contraindicated for them. So maybe Viagra is not an applicable route for them because although it might thicken their lining up, it might cause other issues. There's just like so many different possibilities that it's hard to, you can't ever like apply this to the same, to each patient. But I think that there are some things that are like not going to harm the general population, like taking vitamin E.
Vitamin E, yep.
So, I think that there are, plenty of studies that show that like vitamin E has the potential to thicken a lining. And so that's like it just always stays a part of my, pill repertoire.
Yeah, for
it
transfer.
stays in my pill case that I've shown you. So like, vitamin E, to my understanding, is not going to harm most people, right?
Yeah,
so like
transfer,
right.
It's a great one.
That's something that like you could always add and not have to worry that it would have negative consequences.
Yeah. So just knowing that everyone's history is different, and we take that into account. And if you're ever confused or want to know why we suggested something and not something else, you can always pick our brains or ask us, why did you choose this? Why did you not choose this? And we're happy to explain, kind of the reasoning behind decision making.
Yeah. Or, hey, would this be something that would be a possibility for me? If not this time, but, in a future transfer, or, just learning the why. And I think that we encourage patients to take a proactive approach in their protocol and their treatment plan. Like, we want you to know what's going on with your body and what, so you can always ask questions. We want you to understand the process and feel secure in moving forward.
Yeah. Or, you laughed at the vaginal estrogen. Hey, we've had patients say, I really don't want to, I'm already doing progesterone in the second half vaginally. I don't want to, irritates me, or it's irritating to my skin, or I don't want to do it vaginally. I'm only taking estrogen twice a day. Can I take it 3 times a day? Can I do a patch instead? So there's always, some things we can try and change if, you don't want to do something or you're not comfortable with something.
No, absolutely. Justine, who is our chief nursing officer at CNY, she recently was looking at my chart, and I was on the phone with her, and she said, Laura, is there a reason, this was a modified natural transfer. She said, is there a reason why you take progesterone injections? And I said, absolutely. And she was like, what is it? And I said, because I hate progesterone suppositories.
Oh, yeah, for a modified natural, because
Yeah.
you don't need the injections.
Mm-hmm.
Okay, I would have asked you that too. Ow.
Yeah. So for me, I would much rather take a shot, be done with it, move on with my life. I travel, so I'm on a plane or in a car literally every day. I don't want to have, that's my preference. I don't like the suppositories. They're a little messy for me. Some people would I think most people are like, oh, if
Yeah.
I don't have to take an injection. I think I've taken so many at this point that I'm just like, whatever, I can do it without looking. So.
See, and I would be like, I will do 10 suppositories a day. Those needles for PIO, they're obviously it's intramuscular, and those of you who have done them know that's probably one of the hardest shots in IVF. It's pretty gnarly.
And I think that it's the most feared, people. But for
it's
me,
oily,
I'm
thick.
like,
Yeah.
oh no, it's nothing. That's just my preference. And so she was like, okay, fair enough. And then she was, but that was the question. Like, hey, is there a reason why you're doing? She just wanted to make sure that we were all on the same page. And did you know you could do this? And I was like, oh no, I know, but I just choose not to.
Yeah, so there's always alternatives, and I think it's important, to speak up if you want to do something different, or you want to know if that's an option, or I think it's important to be able to say those things to your provider and then walk through the why.
Right, absolutely.
So, of the things we've talked about in treating a thin lining, change of protocol. Whether that be from a medicated to a natural to a modified natural and vice versa to a medicated. Can we change the medications? Can we change the route? Are we referencing what was your thickest lining during an egg retrieval? So what range should we be aiming for? Mm-hmm. Making sure that there were no med errors, making sure that you weren't exposed to progesterone and didn't ovulate, which is another important point. That's why we don't measure your lining at embryo transfer, because estrogen is what makes that lining nice and thick, and then progesterone will compact it down. So that thickness can actually get thinner and change. So the only thing that we're really looking for on transfer day is that there's no fluid in there, because we have no data on, after exposed to progesterone for so many hours, how much should it be compacted? We're just looking at the thickness, so that's why it's not measured, and I get that question a lot too. As far as the thin lining, what was previous hormone exposure, birth control wise? Should we do a hysteroscopy? Do we suspect scar tissue that we need to fix? And then again, if you haven't had a hysteroscopy, doing that, making sure that nothing is being missed there. So there are a bunch of different things that can cause it, and we do have multiple ways we can fix it, as long as we're referencing what should we expect for this patient, because we know that a certain thickness isn't going to be attainable for everybody.
Right. Everyone has a different baseline. And so what's normal for one person may not be the norm for another person.
Oh, yeah. And I think, we do aim for that 7 millimeters and above, but success can be attainable below that. And more important than thickness, I'm looking at organization. So I want that lining to be trilaminar. People ask me about that all the time. Well, it's not 7, but it's trilaminar. And I usually don't answer those because it's like, well, I don't know what your lining was like at your retrieval. So it's hard for me to answer that. Was it 10 and now you just need a different protocol?
Right.
But I do care about trilaminar lining a lot, and that is something I look at. So if you have done any sort of embryo transfer cycle and your lining is thin, I hope this information has given you, some basis to kind of think, oh, did I just come off birth control? Maybe I need estrogen priming. oh, I think I have a septum, I need a fix, it's been brought up before, or I've been told I have a polyp in the past and I waived my saline sonogram. Maybe I need to get that removed. So hopefully this gave you kind of some information to run through in your head and even ask your provider about.
Yeah, and just from a patient to patient, I would just like highly recommend. Obviously, you do have autonomy at CNY to decide not to go through with an SHG prior to your transfer, but I would encourage you to do it.
Yeah.
I like would never want someone to lose embryos over a procedure that is like so simple and it can be literally pain free.
Yeah.
And like super quick. And it can tell us so much information.
Yeah. And, we have some people that are like, nope, I've done it once, I'm not doing it again. And it's been 2 years. Cool. Do a hysteroscopy. You're asleep. Or you don't, there's so many different ways around it that I wouldn't want you to skip out on something. And this, again, don't be afraid to tell your provider, even if we suggest a saline sonogram and you're not going to do it. Mm-hmm. Tell us, because we may suggest, okay, well, let's do a hysteroscopy. Let's look a different way. And I actually had a question like that today. A patient asked me that. Nope, you don't have to do a saline sonogram. Let's do a hysteroscopy. And she was happy with that. Good, I'd rather be asleep. And that's better. I mean, that's a gold standard test anyway.
Sure.
So sure. So yeah, don't. The more data we have, the better. And it's purely to help you and to get to success. So.
Absolutely. That's exactly right. We want you to be successful. We want you to bring home that sweet baby. Like that's the goal. And so that there's a reason why we recommend, testing to make sure that like we're being proactive versus reactive. And so like whatever we can do on the front end to try to help make sure that you are successful, with the least amount of pain and suffering, tears, we that's what we want for you.
Yeah, so just know that if you've had a thin lining, not all hope is lost. Schedule a follow-up talk, and we'd be happy to kind of walk through that with you. And again, hopefully this show transcript you'll have written down and you'll be able to advocate for yourself and ask some of these questions.
Absolutely. And we would love for you to, subscribe, Spotify, Apple, Amazon, wherever you get your podcast, and leave us a little rating. We appreciate that. That helps us to be able to let us know that, we're doing what's good for you and we're being supportive in a manner that you need.
Yeah, and if there's anything that you want us to do an episode on, message us, comment, let us know, and we're typically happy to cover really any topic. So
yes, for sure.
All right, well, we will see you guys next week.
See you next week.